Good morning, everyone, and welcome to Neurology Grand Rounds. My name is Meridale Baggett. I'm an internist here at Mass General, but I'm also one of the associate editors of the New England Journal of Medicine, case records of the Massachusetts General Hospital. And I'm happy to welcome you guys to the CBC this morning. So we have asked Dr. Albert Hung to discuss this case in the traditional unknown format, which means that all that he knows about this patient is an approximately 2-page summary that I sent to him so that he could prepare his thoughts and prepare his discussion for today. And I do this slightly because it's fun to torture people, and mostly because it's a great educational exercise. It's wonderful to be able to have him teach us about his thought process and how he would think through this patient in real time without the benefit of knowing the diagnosis. So we're very excited to learn from Dr. Hung today as he walks us through his thought process about this patient. Dr. Hung will be joined by Dr. Gupta, who will go through the relevant imaging. Dr. Silverman and Dr. Hilburn will round out our presentation. But it's my pleasure to invite up to the podium Dr. Chui, who's going to tell us about this patient that she helped care for on the neurology service, a 79-year-old man with left-sided movements and transient unresponsiveness. Thanks very much, Dr. Chui.
Hi, everyone. It is an honor to be presenting today's case. I am Carrie. I'm a junior resident in neurology, and I was one of the residents who helped take care of this patient during one of his admissions. So this patient's neurologic story began about 9 months ago prior to his admission when he developed involuntary movements involving his left shoulder and his left base, which later also involved his left arm. The patient described these movements as twitching, and they were intermittent. Initially, they occurred once a month, resolving after 1 to 2 minutes. Over the course of the next couple of months, they have gotten longer and occurred more frequently. 2 months before his admission, they had occurred daily and lasted up to 10 minutes. The patient was initially evaluated by his PCP and had these initial evaluations done. He had a brain MRI, both with and without contrast, that showed a small focus of enhancement in the right middle frontal gyrus that was favored to represent a vascular anomaly. And he also had a routine EEG, which showed brief slowing over the left temporal region. He was then referred to the epilepsy clinic, during which additional history about these movements were obtained. During this time, the patient reported that his episodes began with tingling and numbness in the left leg that then prompted him to voluntarily stomp the left foot. This was followed by what he described as having an uncontrollable, invisible force moving the left arm, left leg, including hyperextending that arm backwards and pronating of that left wrist. There was numbness in the distal portions of his left third, fourth, and fifth fingers and movement of the left cheek. The patient maintained complete awareness during these episodes. Afterwards, he felt fatigued but had a normal level of consciousness and was not confused, and he was started on levetiracetam. On this medication, his movements were shorter but still occurred daily. Later, in epilepsy clinic follow-up, the patient's family brought a recorded video of one of these episodes. And upon review of the video, the patient's neurologist felt they were more consistent with choreoapatoid movements. He also developed dizziness, headache, and generalized weakness, which were attributed to the levetiracetam, and thus a transition to clobazam was initiated and the patient was referred to the movement disorders clinic. His past medical history also included Barrett's esophagus, BPH, chronic HBV, eczema, GERD, hypertension, non-ischemic cardiomyopathy, osteoporosis, and SI-ADH of unclear etiology, and he takes these following medications. There were no family history of seizures. He lived with his wife in Boston, drank alcohol rarely, and did not use any other recreational drugs. On the day of his admission, the patient had movements of the left arm and shoulder that lasted for an hour. And several hours after these motor symptoms abated, the patient's wife found him sitting in a chair, unresponsive. EMS was called, and on arrival, he had already regained responsiveness, but was taken to the ED. His blood pressure was 110/80. Upon ED arrival, his exam was alert and interactive. The lower jaw was held to the left, but the nasolabial folds and the smile were symmetric with activation. He was noted to have intermittent writhing movements of the left arm, which were described as non-rhythmic and non-stereotyped. The rest of his exam was normal, and his vitals were notable for a blood pressure initially to the 150s that decreased to the 130s upon standing, and the patient was admitted. His labs were notable initially for a sodium of 125 that improved to the 130s after a fluid bolus, and a lactate of 2.1 that also normalized. He had an ANA that was positive at a titer of 1 to 160 in a homogeneous pattern, although the rest of his labs, including antibodies to cardiolipin and beta-2 glycoprotein, were unremarkable. And he had imaging with a CTA of the head and neck. This showed severe stenosis of the distal right CCA extending into the proximal right ICA. And he also has severe arteriocortical stenosis of the bilateral paraclinoid ICA and severe stenosis of the left heart. A brain MRI did not show acute infarction. During his hospitalization, he had an evaluation with PT, who noted abnormal movements of the left arm, face, and leg, which diminished with the use of distraction techniques, including the tapping of his thighs, snapping of his fingers, and walking while holding a glass of water. Given the nature of distractibility to his symptoms, there was concern for functional neurologic disease. The transient unresponsiveness that led to the patient's admission was attributed to a combination of hypovolemia and sedation from the clobazam, and thus this medication was stopped, hydration was encouraged, and the patient was discharged home on the third hospital day. Unfortunately, after discharge, his episodes continued daily, and 2 weeks later, he had another spell of decreased responsiveness at home. The patient was doing exercises while seated in a chair and talking to his wife when he suddenly stopped answering. She found him sitting slumped over in a chair, eyes closed, unable to speak other than repeatedly saying yes. The patient was taken to the ED again. And on exam in the ED, he was noted to have a right gaze deviation as well as mild dysarthria with profound left arm, and left leg weakness. His blood pressure was 140/60. A coach stroke was activated and the patient underwent stat imaging. The CT and CTA of his head and neck did not show any acute infarct and essentially showed unchanged cerebral vascular disease. A repeat exam after his imaging showed resolution of the majority of his deficits and showed only mild facial paralysis. At this point, a diagnosis and management decisions were made.
Good morning. It's great to be back with all of you here in the Ether Dome. Great to have an in-person audience. I'm going to try to address the in-person audience and the Zoom audience at the same time. But I really appreciate the opportunity to participate in this discussion of this very interesting case. This is the case of a 79-year-old gentleman who develops new onset of left-sided involuntary movements. And the way that Carrie's presented the case, we see a series of clinical encounters in which his symptoms are interpreted differently by different providers. And it really highlights the challenge of making a diagnosis of an unusual movement disorder, especially one that occurs episodically. So the symptoms begin about 9 months prior to admission when he develops new onset of involuntary movements of the left shoulder and face, which the patient describes as twitching. He gets some initial outpatient workup done, including an MRI and an EEG, but he actually does not first encounter a neurologist until 7 months later, when he's referred to the epilepsy clinic, presumably because of concern that these episodes represented epileptic seizures. Now, what's interesting is that even at that first visit, because the movements occur intermittently, nobody actually witnessed what the movements looked like until he came for his follow-up visit later, when the family brought in a video of the patient's movements. And it was really on the basis of that observation that it raised the question of what these movements might actually represent. He's then admitted to the hospital with a longer episode of these involuntary movements, followed several hours later by transient unresponsiveness. While he's in the hospital, these movements are witnessed again and reinterpreted, raising a question of whether or not they might represent a different type of neurological disorder. And he's referred to outpatient neurology. But unfortunately, before he ever gets to the clinic, he comes in again with an acute presentation of speech difficulty, left-sided weakness, and right gaze deviation, which is really very different than the prior episodes. So as I was first reviewing the case summary, one of the questions that first came to mind is, what type of neurological disorder are we actually considering? His initial presentation is one of an involuntary movement disorder, initially starting in a focal way involving the shoulders and face. But as the case plays out, the possibility of seizure is raised. There's a question of whether this is a functional neurological disorder. And then the clinical episode that actually leads to his diagnosis is an acute stroke. So it raises a question of whether or not this is primarily a vascular issue. I think this is a case where the differential diagnosis is really going to be guided by how we interpret the movements. And my hope is to try and use the description of the movements that were given to try to hone in on a category of disease and to use the ancillary data that were provided to try to help narrow the differential diagnosis further. So let's consider the initial presentation. His first symptoms are described as involuntary movements of the left shoulder and face, lasting minutes without associated loss of consciousness. And I think the first salient feature of the abnormal movement disorder is that they're paroxysmal. They come and go, they're episodic, and at least based on the information that we're given, they fully resolve between the episodes. The next feature is that they're non-stereotyped. They're described in different ways throughout the presentation, but the overall sense is that they occur randomly, they're variable, and they're different from one episode to another, sometimes involving one body part, sometimes involving another. The third key feature is that throughout the course of the presentation, they're hemibody symptoms. They're all restricted to the left side. And that really leads to our feeling that this is likely to be some pathologic process that's originating from the right hemisphere. And then the last key feature is that the movement disorder is progressive, but fluctuates. At the beginning, they last a minute or two. Later on, we're told by Carrie that they lasted 6 or 7 minutes. By the time the patient makes their way to see the epileptologist, they're lasting 10 minutes and occurring multiple times a day. After the patient started on some seizure medication, they seem to fluctuate. They get a little bit better. Some of the episodes only involve the left leg. But then he has this prolonged episode lasting for an hour, preceding his first admission. And so there's something about this disorder that fluctuates, but our overall sense is that it's something that's getting worse over the course of time. So let's start by trying to describe the nature of the movements. So by definition, a hyperkinetic movement disorder is a condition that's characterized by abnormal involuntary movements. And making a diagnosis of a hyperkinetic disorder really depends on a careful description of the phenomenology of the movements. Most movement disorders, we think, are due to abnormal functioning of the basal ganglia. It's usually a circuit disorder, and many times abnormal movements aren't associated with a single neuroanatomic lesion. And so when we're trying to come up with a differential, I think the first step is we need to try and categorize the type of movement disorder that we have. Now, I will say that as a movement disorder specialist, I really hesitate to try to make a diagnosis without seeing the movements myself, because they're really variable. They can be hard to categorize, and it's really that description that's going to guide the rest of our differential diagnosis. But we're going to try based on the information that we've been given. So when we think about hyperkinetic movement disorders, the most common disorder is tremor. Tremor is defined as an involuntary rhythmic oscillatory movement of a body. But there's really nothing from the description that we're given to suggest that these are rhythmic movements. So I think we can take tremor off the list. When we are trying to diagnose dystonia, we're looking for a syndrome of sustained muscle contraction that frequently causes twisting or repetitive movements or abnormal postures. And dystonia can involve any part of the body. It can involve the limbs, it can involve the trunk, the head and neck, the face. Again, from the description, we're not really given a description to suggest sustained contraction suggestive of dystonia. But I think one of the interesting features is that at the first presentation in the emergency room, it was described that his left jaw was deviated to the left. Now, I don't know what to make of this, but that description of jaw deviation is something that we can see with oromandibular dystonia. But I'm going to take that off the list too, because the rest of the movements aren't really suggestive of that. Sometimes involuntary movements can present in a very jerky or irregular way. Myoclonus and tics are characterized by sudden, brief, rapid, recurrent movements. When the patient first describes his symptoms, he describes them as twitching. But later on, throughout the rest of the presentation, that's not really the picture we're given. We're described more as writhing movements, non-stereotype movements. We're really not getting a description that's suggestive of a myoclonic or tic disorder. So I think we can take those off too. When we think about chorea, athetosis, and Ballism, this really reflects a spectrum of disorders that oftentimes occur in combination. So chorea is derived from the Greek word for dance. And when we are trying to diagnose chorea, what we're looking for are involuntary, random, irregular, purposeless movements that flow from one body part to the next. Sometimes when these writhing movements are very slow and continuous, oftentimes involving the distal limbs, especially when maintaining a particular posture, like holding your hands out, we use the term athetosis to describe those movements. The first description of the abnormal movements that were given were based on that patient video. And the neurologist who saw this patient in the clinic described them as chorioathetoid movements. This actually highlights a really important part of working up a movement disorder, and that is that you have to see it. Especially for movement disorders that occur episodically, my advice is to ask patients to have an observer videotape those at home and bring them in to review. Oftentimes, if they can videotape multiple episodes, that's even better because sometimes they're buried. Because it's very possible that when the patient comes into your clinic, you don't see one. And if that's the case, it's really hard to make the diagnosis. Now, Ballism refers to large amplitude flinging movements that involve the proximal extremities. And most of the time, when people present with ballistic disorders, they're oftentimes unilateral, what we refer to as hemiballismus or hemiballism. And so even though we're not clearly given that description here, I'm going to leave it on the list because oftentimes hemichorea and hemiballismus occur together. The term dyskinesia is a term that we use as a general term to describe abnormal involuntary movements of many types. I think the term dyskinesia is most often used by neurologists to describe certain drug-induced movement disorders, like tardive dyskinesia, which patients can experience as a result of exposure to dopamine antagonists, such as antipsychotic medications. Or we also use the term for levodopa-induced dyskinesias, which we see in patients with Parkinson's. Oftentimes, dyskinesias do refer to movements that appear choreiform or chorioathetoid, but it's important to remember that those terms chorea and dyskinesias aren't synonymous and shouldn't be used interchangeably. But again, because I'm a movement disorder specialist, because I haven't actually seen the movements, I'm going to leave the term dyskinesia on the list, and throughout the presentation at points, I'm going to refer to them as dyskinesias. So the first neurological referral was made to the epilepsy clinic. What are the clinical features of this disorder that suggest a possible seizure disorder? Well, by definition, an epileptic seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And it's often associated with rhythmic discharges that can be picked up on an EEG. Most of the time, we think of epilepsy as being a syndrome that originates from abnormal cortical activity, where movement disorders reflect dysfunction of subcortical regions. But this is probably an oversimplification because there's a lot of reciprocal connections between the cortex and the basal ganglia, and there can be sometimes overlap in these symptoms. Now, one of the challenges in terms of trying to make a diagnosis based on the clinical phenomenology is that movement disorders can sometimes mimic epilepsy syndromes and vice versa. So, for example, patients who present with hemifacial spasm, particular periodic limb movements of sleep, or a condition called status dystonicus, can look like they're having a seizure, but there's no electrographic correlate that accompanies these movements. On the flip side, there are certain types of epilepsy, like focal motor seizures or epilepsia partialis continua. These can present with focal involuntary movements, but not have the other clinical features that we typically associate with seizure. For instance, they may not have an aura or loss of responsiveness or incontinence or a postictal state. And so sometimes it can be difficult to try and differentiate a movement disorder or a seizure, especially when you haven't seen it. But I think that one of the features of this case was it was that first observation, the video, that led people to think that this is most likely not a seizure, primarily because of the non-stereotype, non-rhythmic nature of the movements. So when the patient was admitted to the hospital, the possibility was raised, could this be a functional movement disorder? And I think that was primarily because observers saw that the movements were distractible. Now, it's important to remember that the diagnosis of a functional neurological disorder should be made on the presence of positive signs, not on the absence of another diagnosis. Historically, most functional disorders present suddenly, sometimes occurring shortly after a physical injury, oftentimes very mild, some other illness or other trigger. Now, as you all know, it's really important to remember that functional neurological disorders do not have to have a psychological trigger, and oftentimes those won't be present. But most of the time, when people have a functional movement disorder, they're usually most pronounced at the onset or shortly after onset. They really achieve maximal severity pretty quickly. And then over time, they can wax and wane. Sometimes people can go weeks or months or years without these movements. When trying to make a diagnosis of a functional movement disorder, there are a number of positive signs that you want to try and identify on exam. The first is variability. Functional movement disorders can vary a lot in terms of the amplitude of the movement, the localization of the movement, the duration of the episodes. In this case, it was this distractibility that led to concern that this could be FND. But it's really important to remember that abnormal movements associated with non-functional syndromes are sometimes suppressed by voluntary action, or they can actually be incorporated into voluntary action in a way that makes them look distractible when they're really not. There's also other clinical features that we often look for with functional movement disorders. Sometimes they're brought out by attention, they're inconsistent, they can be suggestible when a person is examining them, and they tend to be incongruent with really known movement disorders. They have an appearance that isn't typical of other characterized movement syndromes. Oftentimes, we may also see other functional signs, functional weakness, functional sensory symptoms, an abnormal gait pattern that looks functional. Again, we're not really getting a description of that for this particular patient. There's also a number of other clinical features that I think makes a functional disorder less likely in this case. This is a table from a meta-analysis of about 5,000 patients who presented with functional movement disorder. About 3/4 of them are women, and the average age of onset is about 40. Now, functional movement disorders can present with a variety of clinical phenotypes, most commonly either a tremor or some sort of mixed syndrome. But what you don't see on the list is chorea or choreoathetosis. That would be a really unusual presentation of a functional movement disorder. So I think for the reasons that we've talked about, the demographics, the age, the way that the symptoms evolved over time, and the nature of the movement, I think at this point, the likelihood that this is a functional disorder goes way down. So let's go back and think about this presentation as a paroxysmal dyskinesia. When movement disorders use the term paroxysmal dyskinesia, Most of the time, this is referring to a very rare condition. It's a syndrome of involuntary movements, most oftentimes occurring in childhood and often associated with a genetic etiology. When we define paroxysmal dyskinesias, what we are trying to use to make a diagnosis is what triggers the involuntary movement, the duration of the episodes, and the way that they present. So this table highlights a number of different primary paroxysmal dyskinesias. Paroxysmal kinesiogenic dyskinesia, or PKD, is a condition. Oh, we okay here? Oh, sorry. PKD is a condition that presents with very, very brief episodes of involuntary movement, usually lasting for seconds to minutes, precipitated by sudden movement and occurring up to many times a day. In contrast, paroxysmal non-kinesiogenic dyskinesia, or PNKD, is not provoked by movement, but can be triggered by alcohol, caffeine, emotions, or fatigue. These are often dystonic, sometimes with a choreoathetoid appearance, but these usually last on the order of minutes to hours and occur infrequently, sometimes a few times a week, but sometimes only a few times in a lifetime. There's also other forms of primary paroxysmal dyskinesia, some that are insertion-induced, some that occur in sleep, what we call paroxysmal hypogenic dyskinesias. But basically, I think given the age of onset, given the pattern, I think we can confidently say that the patient does not have a primary paroxysmal dyskinesia. So if that's the case, and if we're going to treat this as a paroxysmal dyskinesia, our differential diagnosis really boils down to what are the causes of secondary paroxysmal dyskinesias. And the list of possible differential diagnoses is very long, including vascular disorders, infection, immune-mediated disorders, toxic metabolic conditions, and malignancy. So I think what we want to try to do is to try and eliminate some of these based on the information that we're given. Some of them very easy to eliminate. We can take tumors off the list. We have the report of an imaging study. There were no mass lesions seen in the brain. We're not given a history of an acute illness to suggest that this was precipitated by a viral or other infectious cause. Based on the data that we're given, there's nothing to suggest that there's an underlying neurodegenerative condition, that there was any preceding trauma, or that this is a result of particular drug exposure. So we're left with a few categories of disease. And I want to start by talking about some of the diagnoses that he doesn't. Rarely, patients can present with acute or subacute onset of chorea or melismus in the setting of hyperglycemia. It's referred to as diabetic stereotopathy. This can occur as the initial presentation of type 2 diabetes, but can also occur as a complication of poorly controlled diabetes. Diabetic stereotopathy is more likely to happen in women than in men, with the average age of onset around age 70. Now, what's interesting about diabetic stereotopathy is that it usually presents acutely to subacutely, but the vast majority of the cases, it's a hemibody syndrome, hemichorea, hemimelismus. And it's associated with a particular imaging finding of CT hyperdensity and T1 hyperintensity in the contralateral basal ganglia. So if I were seeing a patient who's presenting with a subacute onset of a hemichorea, one of the first questions I would ask is, well, what is the blood sugar? Or does the patient have a history of diabetes? And I think if this person had presented to the emergency room at the very onset of the symptoms, that might have been a question that was worth asking. Now, we're given data, this patient has a normal hemoglobin, normal A1C and a normal blood sugar level. And the way the rest of the case plays out wouldn't be consistent with this diagnosis. There's also a number of autoimmune causes of chorea. There are para-infectious causes, particularly Sydenham's chorea, where patients, especially children, can develop an acute to subacute onset of a choreiform disorder shortly after infection with group A beta hemolytic strep. There's also a variety of autoimmune conditions that can present with chorea in the context of limbic encephalitis. Anti-NMDA receptor encephalitis is a condition that's often heralded by neuropsychiatric symptoms, most often in women, and sometimes associated with an ovarian teratoma. There's many types of involuntary movements that can be seen with anti-NMDA receptor encephalitis, including chorea, oral facial dyskinesias, dystonia, stereotypies. But again, the history here doesn't really suggest that. Now, I would say that when I first read the protocol and read the first two lines of a case of involuntary unilateral shoulder and arm movement, shoulder and face movements associated with hyponatremia, the first diagnosis I was thinking was, are these the facial-brachial dystonic seizures that are associated with anti-LGI1 encephalitis? Hyponatremia is a very common lab abnormality that's seen in those patients, but we're also told by Carrie that the patient has a history of SI-ADH of unknown etiology, which could account for this lab abnormality. And I have to admit that as I was going through the protocol after reading the first line, I was saying, okay, well, this fits with anti-LGI1. Maybe this doesn't fit, but let's try to interpret it differently in the context of that anchoring diagnosis. But over the course of the presentation, it becomes pretty clear that he has many symptoms that don't fit with that. There are a number of other autoimmune and paraneoplastic encephalitides, including anti-IGLON5 and anti-CRMP5, that can present with chorea as one of the defining symptoms, but the overall time course doesn't really suggest it. So if I had seen this patient initially with these symptoms, subacute onset, presence of hyponatremia, in addition to doing the initial MRI and EEG, I might have considered some additional workup. I might have wanted to send off a serum autoimmune antibody panel. I might have considered spinal fluid testing, sending off an autoimmune panel from the CSF. But again, as the case plays out, those conditions become much lower and lower likelihood. There's also a number of other autoimmune disorders, particularly antiphospholipid antibody syndrome, which can present with a choreiform disorder. But I think the feature of this case that would make those unlikely is the paroxysmal nature. Most of these disorders have some degree of chorea, can be milder, can be more severe, but it would be unlikely that you'd have a paroxysmal of abnormal movement and then go days or weeks or months without it. So getting back to this case, I think the important thing to remember is that we are not talking about an isolated movement disorder. There's other clinical features of the clinical presentation. Going back to the first description of the episodes, the patient described tingling and numbness in the left leg, as well as numbness in the distal portion of the left third, fourth, and fifth fingers. And those sensory symptoms by themselves could either be a central or peripheral localization, but taken together with these paroxysmal episodes of left hemibody movements, I think it again localizes the disease process to the right hemisphere. We then have to think about how the more recent episodes fit into this underlying diagnosis. He had this hour of involuntary movement. Sounds like the family didn't actually call the EMTs for that because they were so used to seeing it. But it was when he became unresponsive that led to his first admission. And then, as we talked about, the diagnostic clinical event was very different than the other episodes. He had transient aphasia, left-sided hemiparesis, right gaze deviation, dysarthria. All of these are really suggestive of a right MCA syndrome. And the fact that they resolved after a short time raises the question of whether it could have been a transient ischemic attack. So with that in mind, I think this is a good place to stop, and we can take a look at the imaging, both from that last hospital presentation and compare it to some of the imaging that was done previously.
So I want to go over all the radiology imaging that was provided to me. It goes back several months and then comes up So 3 months before the admission, there was an MRI scan that was done. And that MRI scan showed an enhancing focus in the right middle frontal gyrus. At that time, the overall intensity looked like it is similar to that of a vessel. So it was probably thought of like as a vascular etiology. And lesion features are atypical for an neoplastic thing. It didn't look like a metastatic focus. There's no history of any other metastatic disease here. So at that time, it was thought it's probably some vascular anomaly or small telangiectasia or something like that. And there were some scattered microhemorrhages, which are commonly seen in this age group. So this is what let me change the pointer. So this is what it looks like. As you can see that the overall intensity is similar to that of a vessel. But if you go up and down in this series, it'll be delimited. So it doesn't track like a vessel. It's predominantly in the cortex. So even though at that time we thought it was vascular, if you look at the full differential diagnosis, it could be vascular, but it could be a subacute embolic infarct. So very small punctate infarct in the subacute stage when the blood-brain barrier is broken down can actually enhance. And maybe that's what we're seeing. Or it could be metastatic disease, but again, as I said, there is no history here of any other primary that is given. So on the first CTA that was done at admission, this is what we saw. These are thick MIP, coronal MIPs. So you see the common carotid artery and then the distal common carotid artery on the right side. There is this chunky calcification, and it goes into both the internal carotid artery as well as the external carotid artery. And if you look at the individual slices, it is quite severe. The lumen that was left open is very, very small. Something similar is on the other side, but it's much less involved, and it's probably maybe mild to moderate degree of narrowing on this side, but quite significant narrowing on the right side. The same phenomenon is seen in the distal cavernous and carotid. So on the right side, this is the right internal carotid artery, and you can see that there are these chunky calcifications that are narrowing the lumen. And as you go further down, it becomes quite severe. So this was read as severe to critical narrowing on the right side. And the same thing was seen on the left side, where we see a lot of calcifications, where the lumen is significantly narrowed. So this is the summary: severe to critical stenosis of the distal right common carotid artery and proximal right internal carotid artery, secondary to heavily calcified plaque. Severe to critical stenosis of bilateral internal carotid arteries in the paraclinoid and cavernous segments, and then severe stenosis of the left vertebral artery at its origin. I'm not showing you the imaging of the left vertebral artery. Another MRI was done during this admission. And significantly, the prior focus of frontal enhancement that was seen, which was thought to be vascular, was not seen here, which tells me that it was probably not vascular even at that time. And there was no acute infarct, there were no hemorrhages, there is no mass lesion. Another CTA was done 2 weeks after the discharge. Again, it was essentially a repeat of the prior CTA. There was same things, right carotid artery stenosis, bilateral cavernous carotid artery stenosis, and the left vertebral artery. And so essentially the exam was unchanged.
So the most relevant finding on the imaging is severe cerebrovascular disease, both with severe stenosis of the distal right common carotid as well as the proximal right ICA. But we also see significant stenosis in the contralateral ICA as well as the left vertebral artery. So this raises the question, could the movement disorder be related to the cerebrovascular disease, or is this true not related? So the patient's clearly at risk for having cerebrovascular disease. He has a history of hypertension, has a history of hyperlipidemia, what's described as non-ischemic cardiomyopathy. And so I think that the suspicion that he has cerebrovascular disease really isn't all that surprising. The point that Dr. Gupta made about the imaging is interesting because that small focus of enhancement cortically on the first imaging study wasn't seen on the second one. And so it raises the possibility of whether that could have been a very small cortical subacute infarct related to the right MC8 or right ICA disease. So when we think about strokes and movement disorders, especially hyperkinetic movement disorders, these are usually associated with lesions in the basal ganglia and in the thalamus. So the most classic hyperkinetic movement disorder associated with a vascular lesion is hemibolismus, which is often described as being related to a lesion in the subthalamic nucleus, most often an infarct or a hemorrhage. Now, one of the interesting things about post-stroke hyperkinetic movement disorders is that they don't actually begin right at the time of the stroke. There's usually a delay in onset. And that sometimes makes the diagnosis tricky because as a neurologist, we're always trying to think about what are the symptoms that began at symptom onset. Chorea and embolismus that are resulting from a lesion, a stroke, usually begin with within a few days. But other types of hyperkinetic movement disorders, including tremor and dystonia, can have a much more delayed onset, coming on months or even years after the sentinel event that we think was the stroke. And in the cases of dystonia, oftentimes it's usually the hemiparetic limb that develops dystonia over time. In this case, though, we have imaging. We're not told that there was a stroke, and also the symptoms that suggested an ischemic event resolved completely. So can we interpret the movements as being a symptom of transient ischemia? Now, most of the time when we think about transient ischemic attacks or TIAs, we're thinking about negative symptoms: loss of normal speech, weakness, sensory changes, loss of balance. These are the typical neurological symptoms we think of that are associated with the TIA. And when we think of a movement disorder, these are really positive symptoms. But there are descriptions of involuntary movement disorders that come on as a result of transient cerebral ischemia. Limb-shaking TIAs were first described by C. Miller Fisher here in 1962. And the case reports typically associate these limb-shaking TIAs with a high-grade stenosis of the internal carotid artery. The mechanism of action is thought to be due to cerebral hypoperfusion. They can be provoked by changes in posture or head position. And I think it's interesting that in this case, some of the episodes were provoked. One of them, the first one was occurring when he was sitting. We're told that the event that eventually led to his presentation actually was brought on by exercise. And so it raises the possibility that the larger events were related to more of a global hyperperfusion state, but that these episodes of paroxysmal movement could have been more focal ischemia related to the same disease process. And given the overall presentation, given the fact that he came in with what looks like an acute right MCA syndrome, and given the vascular findings that Dr. Gupta pointed out, I would think about referring this patient for urgent carotid endarterectomy, both to prevent a larger stroke and hopefully to see whether or not the movement disorder would improve. So my diagnosis is that these are limb-shaking TIAs secondary to severe carotid stenosis, presenting as a secondary paroxysmal dyskinesia.
Thank you very much, Dr. Hung, for walking us through your thought process with that patient. That was incredible teaching. I'm going to move us to the next slide. I am not Scott Silverman. He is away on vacation, but he recorded his portion. So everyone, please cross your fingers that this goes well. Here we go.
Good morning. My name is Scott Silverman, and I'm a stroke neurologist at Massachusetts General Hospital. I'm sorry I can't be with you in person today, but I'm delighted to be part of this presentation. And today I'll be discussing the clinical aspects of this patient's care. So when this patient presented to the MGH emergency department, he presented with transient findings of a right gaze preference, left-sided hemiparesis. This was felt consistent with a transient right middle cerebral artery syndrome. This was felt secondary to a transient ischemic attack, or TIA, secondary to a severe right ICA stenosis caused by a calcific atherosclerotic plaque. While this episode was different from some of his earlier episodes of recurrent transient left-sided chorioathetosis that mostly occurred when sitting, standing, or with exercise, were also felt to be due to a transient ischemic attack. Some of the earliest descriptions of transient ischemic attacks come from none other than C. Miller Fisher. In his description in a 1962 paper of carotid-related TIAs, some patients had a rather unusual presentation, and he wrote, "The patient may speak of the affected part as trembling, shaking, twisting, drying up, or moving irregularly." Further description of limb-shaking TIAs comes from a paper by Baggett et al. In Stroke 1985. In this descriptive paper, 8 patients presented with this unusual form of carotid-related TIA. The basic features included brief, involuntary, coarse, irregular, wavering movements or trembling involving an arm and hand alone or an arm and hand and leg together. The pathogenesis was hypothesized to be due to low perfusion state. This was felt to be the case because in all patients, they had angiographically documented severe carotid artery stenosis. All patients had stereotype movements that were secondary to recurrent ischemia in the same territory of the brain supplied by the severely stenosed carotid. And surgical revascularization stopped or reduced all the spells, thus making hypoperfusion the most likely mechanism for limb-shaking TIAs. As it relates to our patient, most of his episodes occurred when he was either sitting or standing. And there's a nice paper from Lou Kaplan from 1976 in which he describes positional cerebral ischemia. He describes 4 patients in whom recurrent dramatic transient clinical worsening occurred when patients moved from supine to sitting, despite not having postural hypotension. So in this patient, our most likely clinical diagnosis was limb-shaking TIAs. Shortly after admission to the MGH stroke service, the patient had a carotid artery duplex preoperatively. On the left side of the screen, you see the distal left ICA waveform, which is normal. There is a very sharp upstroke in systole, followed by flow in diastole. In contrast, on the right side of the screen is the waveform in this patient's distal right ICA. This is a parvus et tardus waveform. You see, in contrast to the left ICA, a very low peak systolic velocity, a blunted waveform with a slow upstroke in systole. This parvus et tardus waveform is indicative of flow that's typically seen distal to a high-grade stenosis in the internal carotid artery. Let's move now to the management of this patient. The patient was admitted to the MGH stroke service. He was on aspirin 81 milligrams at home. This was increased to 325 milligrams per day. The patient was started on a heparin drip. He was continued on his statin. He was allowed permissive hypertension to a max blood pressure systolic of 180 millimeters of mercury. Due to the fact that we felt his admission TIA was due to severe carotid stenosis, as well as the prior episodes of involuntary left-sided movements described as chorioathetosis, we felt the patient had a severely stenosed and symptomatic right internal carotid artery, and therefore we consulted vascular surgery. During the patient's admission, he had a right carotid endarterectomy.
Okay, I'll invite Dr. Hilburn to come up and show us the pathology.
Good morning, and thank you for having me. I'm Dr. Caroline Hilburn from pathology. So following the endarterectomy procedure, a 3-centimeter portion of the right carotid artery was received. Within that portion, it included the carotid bifurcation as well as a pre-existing excisional artifact. Grossly, we can notice that there's a flat, slightly raised yellowed region present at the level of the bifurcation. It was also noted that the arterial walls were firm to palpation, consistent with diffuse calcification. The specimen was then serially cross-sectioned, revealing pronounced stenosis. And we can see here that there is a large atherosclerotic plaque protruding into the lumen. And looking at the surface of that plaque, there is some surface irregularity, as well as regions which have a friable character. And given that appearance, it's not unreasonable that portions of this plaque might have embolized, flicking off fragments of calcification or thrombi into the bloodstream. Following the gross examination, a representative section of the specimen was decalcified and submitted for microscopic analysis. And here we have the resulting H&E stained section. Again, we can tell that we're right at the level of the carotid bifurcation because we have 2 large lumina. And at the periphery, there are small fragments of the arterial media. At this magnification, we can see that the stenosis is related to a combination of factors. We both have some intimal thickening, as well as this large, complex atherosclerotic plaque protruding eccentrically into the lumen. The plaque itself is notable for extensive calcification, as well as focal surface irregularity. Now, calcification is a slow process and a sign of chronicity, indicating that both this plaque and the resulting stenosis may have been present for some time. Note also that there are multifocal smaller calcifications present within the intima and which affect both branches of the artery. Here we have a higher magnification view of that largest plaque. And again, this highlights the extensive calcification as well as focal fibrin in between. This view also gives us a good look at the surface of that plaque. And here towards the bottom of the image, we can see there are regions with a smooth, healed surface where we have an intact endothelial lining. But we can also note towards the top of the image that there are jagged regions where we no longer have the endothelial lining present in our section. And these are regions of potential plaque rupture. So ultimately, the specimen was signed out as a complex atherosclerotic plaque with portions of attached media. Thank you.
Okay, let's bring back Scott.
Let's discuss the patient's follow-up. The patient was seen 1 month post-operatively in the stroke prevention clinic at MGH. Since his carotid endarterectomy, he had not had any recurrent episodes of stroke or TIA. In addition, he had not had any further episodic involuntary movements previously described as chorioathetosis. A carotid duplex showed a patent right internal carotid artery. The patient was maintained on aspirin for secondary stroke prevention, and his vascular risk factors were controlled with a statin medication and antihypertensive treatment.
All right, I want to thank all of our discussants, Dr. Chung for presenting the case, Dr. Gupta for going through the radiology, Dr. Hilburn for the pathology, and a big round of applause for Dr. Hung for discussing the difference. We do have time for questions. I'm going to just check the Q&A on the poll. This looks to be within the spectrum of cerebral misery perfusion syndrome, where there's a bilateral ICA occlusion or high-grade stenosis, which can include recurrent TIAs or stroke, seizure, syncope, or cognitive impairment TGA. I'm going to answer this, yes. Any other questions from the audience? Marcella.
Albert. Thank you for the magnificent discussion and vision. Just a quick question. One, we do see patients with chronic stenosis to the highest degree. We don't see cases of limb shaking that often. So, what do you think is the individual predisposition? And second, why do you think this patient did not stroke throughout this many months of limb shaking TIA?
So the questions that Dr. Mattiello asked, which are great questions. One, we have many patients that we see with chronic stenosis. Why do we not see more patients with limb shaking TIA? And the second part of the question is, he had so many TIAs, why did he not stroke? Short answer is we don't know. I think that to the first question, limb shaking TIAs are very uncommon. And I think that again, one of the challenges in terms of trying to localize movement disorders is that there's not a specific localization. Anywhere in the extrapyramidal circuit can sometimes cause these types of movements. And so I think we have to hypothesize that because of this patient's particular anatomy, there were particular branches that went to the basal ganglia that were more at risk. Why didn't he have a stroke? That is a great question. I think that sometimes we teach our residents, well, if somebody is having recurrent episodes and they never complete the stroke, you should think about this as being something other than ischemic. And I think this is one of the things that's so humbling about this case. I think that one could have argued that if the patient hadn't gone to the emergency room, one might not have actually done vascular imaging at all. Typically, if we're working somebody up with a movement disorder, we might we might get an MRI with and without contrast, but we might not actually look at the vessels. So I think that really kind of underscores in this case why it really led to, well, at least the penultimate episode, and then the final episode where he did present with a full-blown vascular syndrome that really led to the diagnosis.
Dr. Gupta?
Yes, if I could offer a possible answer to that question, I think it has to do with the morphology of the plaque. If there is a lot of soft plaque, that tends to rupture and gives rise to the traditional strokes that we see. If it's very calcified plaque, and it has this surface which is unlikely to just rupture and be taken distally, but it is sort of constantly giving you small little thrombi. That is one reason possible for it. But also overall the degree of stiffness. In the setting of hyperperfusion with small thrombi, this is the kind of symptoms. That will be one possible.
So just to repeat what Dr. Gupta pointed out, which is a great point, is that he raised the possibility that the unusual phenotype might have been related to the morphology of a plaque, that a soft plaque is more likely to rupture, whereas he had this hard calcific plaque where they might throw off tiny small emboli, but might not necessarily be episodes that presented with a clinical syndrome. And I think that the MRI finding supports that. He had this very, very tiny embolus to the right frontal region that was clinically silent to the point we didn't even necessarily identify it as an infarct. My guess is if we had done multiple images over time, we might have seen more of those.
All right, I'm going to end this there. Thanks everyone for your participation. Enjoy the rest of your day.